Hello, everybody. It sounds like the room is getting a little bit quiet, like it's about time to start hearing from some of us and start this event. So thank you all so much for joining us today. I am Dr. Sarah Present. I'll tell you more about me in just a minute. Thank you so much for coming. This is a really fantastic turnout, and I'm really excited to see all of you here. I'm hoping we have a really good event for you today, and by the end of this, I'd like to hear more about what we should do in the future to help along these issues. This event is brought to you by many community partners, including the Providence Health Systems, Oregon Pain Management Commission, Care Oregon, and the Clackamas County Health Centers, Public Health Division, and Social Services Division. So we've been planning this for a while, and we're glad that you're here. So my name is Dr. Sarah Present. I am a family doctor. I work part-time in our Clackamas County Beaver Creek Health Center, and the other part of the time I work as our public health officer. So I work for the Public Health Department, and I oversee the medical and clinical aspects of what we do in public health. A couple of housekeeping items. Well, first of all, I just want to tell you a little bit about why we're here and why we've invited you here. I know that many of us have heard about the opioid epidemic in many different ways. You've probably heard about it in the media. You may have heard about it in your families, in your communities, or maybe not. But we also, many of us, experience both acute and chronic pain. And we've heard a lot of mixed messages in the last several years about how to really appropriately treat that pain and where opioids fall in appropriate pain management treatment, as well as how where opioids fall in appropriate management in our communities. And where is that interaction, and how do we find that good balance? So those are the types of things that we want to talk about here today. We hope to provide you with a better understanding of pain and the risks and the limitations of opioid usage for pain, when they're appropriate, when they're not. And we want to talk, and we'll hear from various experts about alternative pain treatments besides opioids and what is appropriate pain management at this point. And with that, I'm going to get started with my presentation. So again, I am the public health officer, and I'm here to talk to you a little bit about why pain management is a public health issue. The management of pain in the last 20 and 30 years has had a big impact into the opioid crisis we have today. I'm going to talk to you a little bit and give you some data about this opioid crisis to put it in some perspective, and then we're going to take it back to looking at an individual and looking at pain management and see how these can kind of find a middle that's appropriate for everybody. We know that the opioid crisis is affecting all of us. We know that opioid medication is dangerous and it's killing people. We know that there is real, true benefit to coming off of them if you're on opioids chronically. And there are things that we understand now about pain that we didn't necessarily 30 years ago, and it helps us treat pain differently and without opioids in much safer, more appropriate ways. Safer for individuals and safer for the community. So some numbers here. This slide shows you some context of the total, or the number of deaths and the peak year of different aspects. So the peak year of overdose deaths was actually 2017, when there were over 70,000 drug overdose deaths. Over 3/4 of those were due to opioids, which is more than the peak year of car accidents, HIV and AIDS deaths, suicides, homicides, and the Vietnam War. I did hear on the news just this morning, actually, that the life expectancy in the United States actually increased this year because of the decrease in opioid overdose deaths. For the last several years, our life expectancy in the United States has been decreasing, much in part due to the increase in opioid overdose deaths. So what's an opioid? Basic things here. Opioids are made from the opioid poppy or plant, or are artificially produced to have similar effects. They are a class of drugs that are either produced from the plant or created in a lab to have the same effects. Some opioids are medicines, some are illegal drugs, some look like medicines but are actually illegal drugs. There are a lot of counterfeit pills in our world right now. Medications are used to help treat moderate to severe pain, and they're often prescribed after surgery, an injury, or other health conditions like cancers. But all opioids are the same similar compounds. They are all addictive, and they are abundant in our community. To start the context a little bit about the issue with prescription opioids and put it into some context, we in the United States are less than 5% of the world's population, and we consume greater than 80% of the world's supply of opioids. That's prescription opioids. We have seen a really very close connection between opioid prescription sales and increases in addiction and increases in overdoses. We do not, in the United States, have over 80% of the world's pain. I think that we all know that we are all humans, and we are treating pain in the United States differently than other countries, and we are seeing the effects of that. There are many, many factors that contribute to our opioid crisis right now. We have a lot of pills out there. So a lot of prescription pills that have been pretty inappropriately prescribed over the last several decades. As a family doctor, I know that we in medicine were trained many years ago that opioids were safe, that opioids worked, and that people wouldn't get addicted if they were used for pain management. We know now that all three of those statements are false. Opioids are not safe. Opioids really don't work for chronic pain, and people do get addicted. It is a biologic fact that the opioid compound works in our brain in a way that anybody who takes it is susceptible to addiction and to problems from it. We know that if you're on an opioid for just a couple of weeks, your significantly increased likelihood to have to be physically dependent on them and have addiction issues. So anyone over, really, if you're on an opioid for on average 2 weeks, you will begin to have physical dependence. If you're on it that long, the risk of having problems in the future coming off of it just skyrockets. We know that small overdoses can kill, or small amounts can kill. So this is a powerful compound in the way it works in our brain, but also a powerful compound in the way that it can stop us from breathing very easily. And then many of the opioid analogs, the synthetic opioids that are coming out, are much stronger than heroin. We've heard of fentanyl analogs that are killing people because just a small amount can kill very quickly. We also know that opioid use disorder is a chronic and relapsing disease. So anybody is susceptible. And there are lots of underlying social factors that go into this that we are not going to go into today. Just another look at our opioid crisis. It's emerged in 3 waves. The first wave was because of inappropriate prescribing and overprescribing in our country. We have controlled our medical prescribing a fair amount. We as medical providers have learned a lot more about what appropriate pain is. And in the meantime, heroin and fentanyl have gone up. So there's a big connection here that we don't have time to go into all of that, but the prescribing part has been really the beginning of our crisis in our country. And it's similar in Clackamas County. So on average, we're having about 20 overdose deaths per year in Clackamas County. The majority of them are due to prescription medications. Statewide, Oregon, we are lucky in that we are not the highest in opioid overdose deaths compared to some other states, but we do rank one of the highest in prescription opioid abuse in the US, or people misusing their prescriptions. We rank in the top 10 states for non-medical use of prescription pain medicine. In 2016, there were 220 million opioid pills prescribed to Oregonians. That's enough for every person in Oregon to have 55 opioid pills. And we have, on average, about 5 Oregonians dying per week due to overdoses involving opioids. Another link around the prescriptions and how it affects our community opioid epidemic. This is from a survey for people who have used pain relievers for non-medical use, so people who have used them inappropriately. Over half of them got them from their family or friends for free. 22% of them got them from a doctor. They got them prescribed, but they were misusing them. And over 4% stole them from a friend or relative without asking. So what are we in public health doing? We have goals to decrease the harms and the deaths from opioids in our community. We know that our community is impacted and it is a public health issue. And there are many ways that we in public health go at this to address this issue. We look at the data to inform our work and target interventions on where they're needed. We are working a lot on expanding recovery and expanding overdose prevention through expansion of naloxone services. But we also need to work with our partners, like we are today, on safer prescribing and the use of non-opioid pain management for the treatment of chronic pain. We also work with our medical providers to help ensure education around safe prescribing. But we really need to work with our community partners and improve care coordination so that people who have chronic pain get the treatment that they need and the pain control that they deserve in a safe manner. Again, we respond by decreasing the harms and deaths from opioids, supporting recovery, safer prescribing, strengthening our community, and improving the understanding of pain and how to change it. So that is what brings us back to what we're doing here today in trying to improve our understanding of pain. I'm going to give you a story now. This story is a theoretical patient. Many of you may have known somebody quite like this. I have known several patients who end up on chronic opioid medication in a very similar way. So this is Mary. Mary's first visit to her provider, she was seen for left knee pain for 8 weeks. She didn't have any injury, she didn't fall, it just started gradually. She's not exactly sure when, but it's been getting worse and worse over the last 2 months, and her pain is currently at a 7 out of 10. The first steps her provider ordered was an x-ray, a referral to physical therapy, and gave her some Vicodin, which is an opioid, to use as needed for the pain. She came back 2 weeks later. Her pain is not any better. She's taking the medication every day and multiple times a day, which is possibly at dangerous doses. She feels that the physical therapy caused more pain than it improved anything. And her x-rays showed moderate to severe osteoarthritis in her left knee. Her plan from here, they stopped physical therapy because she was really not feeling a benefit from it, and she thought it hurt more. And they switched to a long-acting opioid, so one that you take once or twice a day rather than every 3 or 4 hours to help control her pain throughout the day. 1 year later, her pain continues. She's had joint injections. She's had a knee replacement. Her opioid medication dosages have increased, and her pain has spread. Her left leg is painful still, as well as her right leg, and her pain goes into her back and into her neck in ways that the tests and the imaging are not able to explain. Her thoughts at this point is that her life is unmanageable, and that her pain medication is the only thing that actually helps her. She thinks, I need to take it easy because of my pain, and it's not safe for me to do very much because it makes pain worse. My pain is terrible, and it will never get better. So this is not an uncommon situation right now. At this point, I am going to pass it over to a next speaker, Kevin Jin, and he's going to continue Mary's story for you with a little more explanation on how he would address it. Kevin is a physical therapist with Providence Milwaukee Healing Place. He graduated from Samuel Merritt University in Oakland, California, and he greatly enjoys the diversity of his job and the people that he gets to help. Kevin?
Hello, everybody. Can you hear me in the back? Okay. So I'm going to continue Mary's case throughout this, as well as talk a little bit about how we understand pain a little differently than maybe we used to. And so at this point, we're wondering if she's had a knee replacement, the damaged tissues in her body have been replaced, even a year later. Why is she still having pain? So we'll explore that a little bit. So just to recap, she's had the knee surgery and things aren't getting better. They're even spreading, which doesn't really make sense with the tests that have been done. And so we used to think that pain came only from the body and only when it was injured. And so our thinking about that is starting to shift with that. And I'll explain and give some information that supports that. And so if pain only comes from the body, how can we explain that she still has this knee pain? And if the arthritis has been replaced. So I'm going to talk here a little bit about how the pain is complex and how it works. Here you can see we have inputs into the body, which might include sensations that we experience. And from there we have nerves that information travels up to the brain, and that's where that information is processed. This information is processed to assess the importance of it, the danger of it, and depending on how important it is at that moment, an output may include pain if we feel that we need protection. Okay, so that is the basic mechanism for how pain works in the pathway. So we'll use an example here to give us insight into how pain can be different depending on the situation. So let's think about how a little boy who falls off his bike and his mother is watching nearby. He falls off his bike, scrapes his knee. The mother, he looks up at his mother in distress because of the sight of blood and worried. And as a response, the kid cries in pain, also responding on the mother's distress. But if we use another example of the same situation where the boy falls off his bike, but the mother is no longer there, the context of the situation where he doesn't have the external information from his mother that he should be worried or distressed might ride home proud. And this kind of just gives an example of how the situation may differ, or the experience with pain may differ depending on the situation. So some things to think about. Have you ever had pain that is spread to new areas? Or had pain that gets worse with stress? Or even had pain decrease when you're having fun? And so these are things that tell us a little bit about how pain is influenced depending on the situation. So some key things to consider and keep in mind is that with all this talk, we have to confirm that all pain is real. Okay? Everyone's experience with pain is different. And so lots of things can contribute to our pain experience, including past experiences, things we've been told, how much this all influences the things that are important to us. And so pain is less to do with harm and more to do with a threat. So here we'll distinguish the difference between acute and chronic pain. So typically we think of acute pain as pain that occurs with an injury, and that pain resolves and calms down as the healing takes place. But with persistent pain, injured tissues typically have healed in an expected time frame, but pain can persist beyond this time. And so in some cases, this pain can persist for months or even years, and this is widely understood as persistent pain or hypersensitivity due to a combination of ongoing overuse patterns, inflammation, neuropathic pains. What does evidence of damage tell us in relation to pain? There are studies to suggest that up to half of people with severe arthritis of the knee or even the spine may not even have pain. And so what that information tells us is, this is important to know because we cannot know how much pain one is going to experience based on the amount of damage or degeneration that may be seen on an image. There are so many other variables that will contribute to somebody's pain experience other than what we see in the picture. So worse bodily injury does not always equal worse pain. So I'm going to talk about how the fight or flight response influences our whole experience with pain. So just an example here to demonstrate that. There's a young deer here that's grazing. Okay, calm, heart rate is resting, blood pressure is normal, digesting its food, and all of a sudden a cougar jumps out from the bushes. Things change immediately, and this causes the deer to respond in a way for it to survive. So its responses are increased heart rate, increased blood pressure, and And so its digestion and rest are all put on hold, all for its survival. And so after it scurries away and luckily escapes the cougar, it's able to return back to its resting state and continue on feeling safe. And humans have the same ability to do this, but I think we're more advanced in a way that sometimes we can stay in that hyper-alert state for longer, and it can be harder to lower that level of threat, all in an effort to protect us. And so this can happen with pain if the threat persists. So bringing it back to Mary, we learned more information about her story. We dove deeper. We're still trying to figure out why she's having so much pain despite the injured tissues being replaced. She shared that around the time of her pain worsening was the unexpected death of her mother. She expressed thoughts that she didn't think it was safe to be active for concern of injury. And she thinks that medication is the only thing that's going to help. She's not sleeping a lot. She frequently is napping. She's very depressed and isolated. She even shared vague details of childhood traumas. So there's a lot going on for Mary. She's unemployed. She lacks the energy for hobbies and fun. She doesn't cook anymore, and her diet lacks healthy foods. So we have to ask, where do we start? What besides opioids can we do to change our experience with pain? Understanding that there's multiple ways to approach it can provide a sense of optimism. Understanding how pain works, that can set a foundation. Consulting your doctor, your physical therapist, occupational therapist, or other rehab professionals on how to progress activity at the right pace is important. Making smart food choices, getting help with changing your outlook if that's needed, and working on better sleep habits. And so working with specialists in each of these areas can help motivate and keep people accountable if needed. So in the back we have some resources. The Oregon Pain Guidance has put together a pain education toolkit that can help navigate these different key domains that I was just talking about. And so if we work through Mary's case, her new plan is that the doctor's given her some resources to try to make some positive changes. She also commits to setting some goals for herself, for improving her sleep. She wants to try working on some relaxation activities, meet with a counselor she's considering, and she's looking into accessing a local pool for exercise, and even contacted a friend to start walking around the block. And for Mary, her outcome looks like this. She's pleased with her progress, but she knows there's a lot more to do. She's less fearful of movement, but she sets boundaries to go slow. She's able to nap less. She gets better sleep. She's meeting regularly with a counselor. Her and a friend are walking regularly around the neighborhood, and she's participating in a water aerobics class. She's more focused on expanding her life, and the emphasis of pain has reduced. And so just to summarize, we want to acknowledge that pain is real. And lots of things contribute to that pain experience. And pain has a lot more to do with threat than it does harm. And for those that are just starting to get back into moving more, we want to start off slow. Thank you very much.
Next, I'd like to introduce Nora Stern, who's going to interview a patient who will share her story on living with chronic pain. Nora is the chair of the Oregon Pain Management Commission. She is a physical therapist who's been working with complex pain for more than 25 years. She works with clinicians and patients to change the conversation around pain and is committed to helping our state change the way we understand and treat pain.
So before we get started on our interview, I want to just ask folks, because we just heard a lot of information from Kevin. And so I want to just do a little check-in. We have these kind of provocative statements, like pain and harm are not the same thing. I mean, I want to pause here for a moment because that's actually a mouthful. There's a tremendous amount in that statement. And it might sound like that's kind of a crazy thing to say. So I want to just ask folks, if you think for a moment about the idea of having pain without harm, can you think of a circumstance that you've had or that somebody you know has had where they've had pain, where you or they have had pain without actual bodily injury going on at that time? Just shout some things out. Migraine headache. A migraine headache. Or any headache, most headaches, yeah. Yeah, where there's something happening in the brain, but it's not tissue damage. Yeah, what's another one? Back pain could be, depending on what's going on. You could have had an injury and have something that you could find in the tissue, but a lot of the time it's long-standing and there's no tissue injury going on probably. Yeah, yeah. What else? Depression and feeling physical pain? Yeah, depression and, whoa, that's a big one. Yes, yes, mood and pain are incredibly closely connected. And you can feel pain all over the body when you feel cruddy. What's another one? Yeah. Fibromyalgia. And fibromyalgia and depression are very closely connected because the brain is the place that produces pain. And it produces pain because you feel that you're under threat of some kind. And if you're feeling bad emotionally because of depression or anxiety, it's like, well, when's the next shoe going to drop? And then the sensations that you feel will feel more intense. And if one of those sensations is pain, you're going to feel it more intensely. Yeah, what's another one? Yeah, yeah. So that's a good. So arthritis, the different arthritis is so that's a complicated one, and that goes back to that X-ray. There is some degeneration going on, but the evidence also shows that there's actually a very low correlation between the amount of degeneration that you have and the amount of pain you'll have. Yeah, what's another one? Parkinson's, you can feel pain from Parkinson's. Yeah, there's complicated brain functions going on here. So another where you don't actually even have the tissue anymore, but you can have profound pain in the remembered limb. So the reason for that is because the brain has a representation for that part of the body, and it's running a pain experience based all on that complex brain mapping and has nothing to do with the input coming in from the body part. Amazing, right? And then you can flip that, harm versus pain. You can have harm, like in a battlefield injury, where you have incredible tissue damage, but because of the tremendous threat going on all around you, the brain can't process the tissue damage at that time, and people won't even realize that they lost a body part. And on the other side of it, you can be having a good time with friends and realize that you weren't feeling pain during that time, right? And it probably, has anyone had that experience? Yeah, most people have. And it's because your brain's not interested in threat at that time. It's interested in something else. So that's what this is all about, is the brain's amazing ability to create pain and reduce pain. And it tells us that we are incredibly empowered to change our own pain experience, well beyond anything that opioids can do, because opioids can't do that for you. So I am very privileged to have with me my friend Nancy, Nancy H. Collins, and she and I were able to work together in my previous setting with Providence. And Nancy's a retired psychologist with a tremendous lived experience of life, of great adventures, and then also some tremendous pain setbacks, and she's going to share some of those with us, and then some of the things that she's learned. So thank you, and give a hand to Nancy for coming and standing up here, if you would. It's a pleasure to have you here. I'd like to ask you if you would explain a bit about your pain experience to us.
I love to talk about myself, so I would be just delighted to share in as brief detail as possible my pain experience. It began 20 years ago. Out of the blue, no reason, I began to experience intense agonizing, unstoppable, unexplainable pain in my truncal area. It extended all the way around the front to my back. There was no relief. I've never felt, and hope never again, to feel that level of pain for 2 months. Emergency room visits, pain doctor visits. I took every pain medication available, nothing helped. Finally, I'm a member of Providence. I work for Providence. So I love Providence. I go back to the ER, and this time I was paralyzed on my left side. That got the attention of the physician in the emergency room, and I was very clearly cognitively impaired. I could not string a sentence together. I, as Nora mentioned, was a psychologist. I know what hallucinations are, and I was experiencing hallucinations. Never before in my life had I had anything like that. The hallucinations were auditory and visual. So I was admitted to the hospital. I spent a week on the medical floor, tests, imaging, blood, and the final diagnosis was pulmonary and neurosarcoidosis. It is an autoimmune disease. Many people have it, particularly pulmonary sarcoidosis, and with treatment, prednisone, I got better. But my brain, that is another story. I was 2 weeks on the rehab floor, and I learned to walk and use my left arm. I was discharged after 3 weeks. I went home with a walker. I was aware that it was the all-time life-changing experience for me. I can't say at that point of time I was in pain, but I knew that my life would never be the same. Cognitively, I was not nearly as wonderfully bright as I once thought I was, and I was very humbled to discover that that was a fact. I lost what are considered IQ points, intelligence points. I wasn't as smart anymore. Today I'm smart, but I'm not super bright, and I have definite cognitive areas that are well beyond me. In 2005, I started having pain, and I was waiting for this to happen because the kind of neurosarcoidosis I have is so incredibly rare that doctors don't know anything about it. It's really only been in the last 3 to 5 years that they've studied it. And I had pain from 2005 until, well, 18 months ago, maybe. I lived with it on a daily basis. You can imagine what the psychological side effects of that are, and we're going to talk about those later. And that's about it. I am the queen of pain. Was the queen of pain.
So let's find out more about, so I'd like to ask you now, we have to go back and forth here with the mic, sorry. Early on, tell us when you got prescribed opioids, if you would, before I go on.
Well, in the year 2007, after I'd been experiencing a great deal of pain, I went to my primary care doctor. I'd complained about it before. She prescribed oxycodone and morphine to be taken twice a day. And for 12 years, I faithfully took those medications. I knew when I started taking the medications they were addictive, and to be honest, I didn't care because I was sick and tired of being in pain.
So I want to pause there for a second and ask you, when you first went on opioids, because I think this is critically important, can you explain a little bit about, I was listening to your story and I was listening to the fact that what you said, I was waiting for the pain to come. And I hear that as a pain educator and I think, how scary to live with feeling like you're waiting for the pain to come. So I think threat. I think there's a setup there for having complex pain because that's so threatening. And I want to know, when you were prescribed opioids, what was your understanding of pain itself and what your options were, what you understood at that time?
Despite my previous brilliance, I found out that I knew relatively nothing about pain. I didn't know about the fight or flight. I didn't know about the sympathetic and the parasympathetic nervous system. The doctors offered me over 12 years, not one option, except possibly physical therapy. And this condition has no known cause, no known cure. It's chronic every 2 to 3 years. I have what's called a flare that lasts from 6 to 12 months, and that's very unpleasant. And I'm digressing, so I'm going to let you bring me back.
So would you say it sounds like when you were prescribed opioids, you were given the option of physical therapy, but you didn't really have an understanding of how pain worked in your brain and nervous system. Nor did most people.
Not a clue.
Yeah.
Not a clue. I'd studied neurology, but that was, 50 years ago, excuse me.
Yeah.
Nobody knew.
And our understanding of pain has changed a great deal. So now, looking back, now that you, as we say, have drunk the Kool-Aid and have a different understanding of pain because of the work that you've done over your journey, I'd like to know, let's see, how was I thinking this? What do you see now as your treatment options, and what is your understanding of pain now? And as you look back on where you were at back in 2007, what would you want to have been able to do differently?
Wow, have the gift of reliving my life, that would be wonderful. If in 2007 I had understood the dynamics of pain, how it works in your brain, as Dr. Jen very eloquently described, I was ignorant. I had an incredible revelation 2 years ago. And if I had known then what I know now, I would not have taken opioids and become dependent on them. And I'd be happy to talk at some point about what that's like, to know you need those opioids when in fact they're not doing you a bit of good. The first 2 or 3 weeks, they were fabulous. And then I just kept taking them because I'm one of those compliant people who believes in doctors. And I never had a problem refilling them. I was terrified, of course, I couldn't refill them, or God forbid I'd lose them. I mean, I think I had the addict's brain. And I know I've digressed again. So
building off of that, it sounds what you're describing here, it has to do some, I think, also with fear, right? With fear of what might happen without opioids, but also just what might happen for you in your life in general. If you could talk a little bit about how you now understand the relationship between fear and pain, because pain is pain and not understanding something that's going on that doesn't have a good answer to it is, it's very scary, right? And there's a reason for that that's closely linked in the brain. Can you talk about that a little bit?
Yes. There are two nerve systems basically in the body. The sympathetic nervous system, which was elicited when the cougar attacked the deer. All your senses are alerted. You are in the fight or flight syndrome. And when you feel fear, anxiety, accompanied, of course, by pain, not knowing what the future is going to be, depression is huge. You go and you experience fear, anxiety, depression, which is kind of inevitable over a long period of time. Your brain kind of becomes frozen, and panic reactions set in. I also didn't mention anger. You know, we don't talk about anger a lot, even in the pain program I've been in. But boy, I was pretty angry. And I called it impotent rage. It's like rage you can do nothing about. You can do nothing to change it, nothing to alter it. But it was through the pain management program and all of the experiences I've had there, which I'm going to talk about in a little bit of detail. Please do. Okay. So 2 years ago, my primary care doctor, for the first time in the history of my experience with opioids, suggested that, gee, this might not be such a good thing for me. And of course, that set in panic. And I thought, if I withdrew from them, I knew I was going to have a very negative response to that. I was going to be very ill. But he referred me to the pain management program, and I was presented with a very interesting option. And that was I willing to taper my dose down very gradually and just see what happened? And I was also told if it didn't work, well, we'll go back to where you were. So I'm smart, sort of, and I said, yeah, I'm willing to do that. And over a 3-month period of time, gradually reducing the morphine and the oxycodone, I was off of them. I never miss them. I don't think about them. I don't need them. It wasn't a magic cure for pain I continued to have until I entered the real pain management program, where I learned all kinds of information about the second type of nervous system that we have, and that's our parasympathetic nervous system that calms us, that encourages us to breathe. I thought I knew how to breathe. I bet if you guys think you know how to breathe, I was wrong. There are many, many different kinds of ways that you can breathe and calm yourself. All the fear, the anxiety, the uncertainty, the depression. So breathing was critically important. There's diaphragm breathing, belly breathing, different nostril breathing. I'm telling you, it works. You just have to practice it. I started this whole process with my wonderful physical therapist, Nora. I have had horrible balance issues since the year 2000. I have fallen more times than I can possibly tell you. Nora always encouraged me to use a walker, and sometimes I did, and sometimes I didn't. And I've broken bones, and I'm still working on my balance, and I work on my balance through what I call mindful movement. And initially, all that means is I sit in a chair with a group of other people who are also in pain. And it begins with the most gentle stretching and movements. And I was in a group with people with many different diagnoses. I have to say, in my group of women that I met 18 months ago, we're still together. We may have lost a couple of women, but everyone has consistently gotten together because the educational portion of this program talked about nutrition. I thought I ate a good American diet, and I inverted the food pyramid and realized vegetables were really at the top. I thought I had a really good understanding of my nutrition, and I didn't. It made my food made my pain worse. Stress, the worst of the worst. Stress is our biggest enemy. It just absolutely 100% increases our pain. And stress comes from all different ways, and the more threat, the more pain, the more calm, the less pain. I loved this program because it never used the word exercise. I hate exercise. Not one time have I ever heard that word. And mindful movement is so calming and so gentle and non-threatening. How could that not sound wonderful? So for almost a year, I just sat in a chair with an instructor and I started to stretch. And I found out I am very flexible. I can touch my toes. I don't know if you know what downward dog is. I can do it. I'm not going to do it for you today, gratefully.
Give her a moment, she probably.
Give me a moment. I would. I'd keep my butt that way. Anyway, I have graduated from chair exercises. I have done acupuncture, Tai Chi, yoga now, and Pilates. And 4 days a week, I go to my movement classes. And now it's hard for me to just stand still. I want to stretch. And that is a miracle. Counseling and peer support were critical. You have to accept that as a part of healing. I've made friends. If I don't show up to a class, I get a text. I get a phone call. What a blessing. The pain isolates you. You give up your usual activities. It hurts when you move. The less you move, you think, the better you're going to feel, and it is, in fact, the absolute opposite of that. But you have to do it slowly, gradually, patiently. You have to be a persistent person. You have to decide, can you change? Can your brain change? Yes, you can change your brain. Some things don't change, but you can change your responses. And I expect I've gone over as I always do.
That was awesome. Thank you very much, Nancy.